Hello, good morning, good afternoon, good evening to all the speakers, chairs, and audiences in different parts of the world. Welcome to the ACNS webinars. The speaker for the first session today is our honorable guest from India, Professor Sanjeev Kumar. Professor Sanjeev Kumar is a professor in Department of Neurosurgery, DKS Postgraduate Institute, and Research Centers, Raipur, Chhattisgarh, India. He has special interest in the management of cerebral vascular surgery, cranial endoscopy, skull-based surgeries, and neuro-oncology. He is a noted author who has published 54 research papers in international journals. He is also an innovator who has developed the innovative technique of extra-axial endoscopic third ventriculostomy for managing hydrocephalus. We are extremely honored to have him today at our webinar, and today he will be talking about endoscopic keeping of Acom aneurysms. The speaker for the second session of today is Professor She Zhiyong, MD, and attending from the Department of Neurosurgery, Nanjing Drum Tower Hospital, Nanjing University Medical School. Professor She Zhiyong mainly engaged in the treatment and clinical research of cerebral vascular diseases, such as Moyamoya disease, cerebral aneurysm, arteriovenous malformation, cortex stenosis, etc. Currently, he's in charge of National Natural Science Foundation of China and clinical project of Nanjing Drum Tower Hospital. He has published 10 SCI articles and Chinese core articles as the first author or corresponding author. We're extremely honored and grateful to him for accepting our invitation to be a speaker for our webinars. And today he will be talking about research of cerebral hemodynamics of extracranial, intracranial bypass for complex middle cerebral artery aneurysms. The chair for today's webinar is the honorable faculty from the Japan, Professor Hidetito Kimura. Professor Kimura is a consultant neurosurgeon at the Department of Neurosurgery, Kobe University in Japan. His clinical interests are focused upon the management of cerebrovascular diseases. He is a noted author with several publications in various peer-reviewed journals. We're extremely grateful to him for accepting our invitation to chair today's webinars. On behalf of the Educational Committee of ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and the chairs and the audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely thankful to Professor Xu Bin for broadcasting the webinar on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today. With that introduction, I would like to hand over this online podium to our Honorable Chair, Professor Hidekito Kimura. Professor Kimura Sensei, please.
Okay, thank you, Dr. Ben, kind introduction. So once again, thank you for inviting me again. I'm very, very glad to see you and my honor to be invited again here. Thank you. And okay, now today's first speaker is Professor Sanjeev Kumar from India. Thank you for very much for joining us. And he will talk about, as Dr. Ben introduced, endoscopic clipping of Acom aneurysms. So if you, okay, please start your presentation when you're ready. Thank you.
Thank you, sir. Greetings from India. I am grateful to ACNS team, especially Dr. Raja, for inviting me to showcase my work. I have nothing to declare. After seeing the title of my presentation, the most striking question which I have faced during my earlier presentations is why use an endoscope when everyone is quite comfortable with microscopic clipping? The answer is very simple, and we all already know that. The difference is in the vision. The endoscope provides a panoramic, close-up, and better illuminated views. With angled scope, you can look around the corners. These advantages in vision has made endoscopic surgery so popular. If you see evolution of the neurosurgery, you will find a trend. Initially, the surgeons were quite comfortable with open surgery. Then the introduction of microscope changed the whole scenario, and surgeons got comfortable with it. With introduction of endoscope, the neurosurgeons who were well versed with the microscope were little hesitant to use endoscope. But slowly the trend is changing, and with the advancement in technology, every neurosurgeon is getting comfortable with the endoscope. The use of endoscope is increasing day by day in both cranial and spinal surgeries, and even replacing many microscopic surgeries. Let me put it in this way. If you had a chance to visit the Taj Mahal in India, you must have noticed these two views. The first view is through the outside of the main gate. Consider this view as a macroscopic view. And here you can see just what the boundary of the gate permits. Now look at the second picture. When you have crossed the front gate, you get a panoramic and close-up view of the whole of the Taj Mahal. This is the endoscopic view. Now similar Taj Mahal in respect to the anatomy of an Acom aneurysm. Consider both front tower as bilateral A1, both towers in the back as bilateral A2, the base as Acom, and main building as aneurysm. The first picture, which simulates microscopic view, you can see only the limited structures. For visualizing adjoining vessels, you need to tilt and refocus the microscope. While in the second picture, like an endoscopic panoramic view, you can see everything in a single view. And this is the actual comparison of microscope and endoscopic clipping of ruptured Acom aneurysms by a right supraorbital keyhole approach. In microscopic surgery, the craniotomy ace restricts the field of vision, and the surgeon need to adjust the microscope angle and focus repeatedly. But this is not the problem with the endoscope. With an endoscope panoramic view, you can see the all adjoining vessels simultaneously before clipping. There have been the two ways of doing endoscopic clipping of Acom aneurysm. First one is endonasal transtubercular transplanum route. Many neurosurgeons have described endoscopic endonasal clipping, and this is a systemic review of all those publications. If you look closely, except for one instance, endoscopic clipping of ruptured Acom aneurysm has not been reported. And if you go through all these publications, you will clearly notice the technical issue encountered with endoscopic endonasal clipping. Endonasal clipping is anatomically suitable only for superiorly and inferiorly directed aneurysms. Even with this orientation, the distal clip gates cannot be visualized easily. For anteriorly directed aneurysms, the fundus is encountered first. For posteriorly directed aneurysms, the aneurysm remains hidden behind the Acom. The second anatomical issue is the proximal. If the proximal A1 is arching deeper, it is difficult to get proximal control. In the narrow space of endonasal exposure, if a temporary clip is required, it will hinder the permanent clip application. The most striking limitation is an intraoperative rupture. The rescue becomes very difficult. And even if all goes well, sometimes clip shunts do not allow a proper dual closure, increasing the risk of a CSF leak. Endoscopic assisted microsurgical clipping has been done for a long time. This meta-analysis of 1432 patients, which was published last year, clearly shows that 13% in 13% of cases, repositioning of clip was required. In some studies, this number was as high as 24%. And 77% of patients treated with endoscopic assistance have a better outcome than a microscope alone. And endoscope-related complications were there. These results shows that endoscope has certain advantage over microscope alone. In these cases, the initial dissection was mostly done with the microscope. Then the endoscope was used for either for additional dissection, or clip application, or clip adjustment, or perforator preservation. So logically, if initial dissection can also be done with the endoscope, we might not require the microscope at all for Acom aneurysm clipping. The older and routine endoscopic system lacked 3D vision, but the newer 3D versions are now available. The surgeons who have been using endoscope for a long time are well adapted to the 2D views. I am still using the older 2D version. And newer endoscopic versions have ICG facility as well. I don't have this facility. An intra-op ICG can ensure the gross patency of the vessel. The residual aneurysm and subtle flow changes are best seen on DSA. There are many reports suggesting the disagreement between the intraoperative ICG and postoperative DSA. A clear view of all adjacent vessel is a prerequisite before clipping an aneurysm. An intraoperative ICG can visualize only the exposed segment of vessel. If the bilateral A1, A2, and Acom arteries are clearly visible during surgery and identified before clipping, there is no absolute need for an ICG angiogram. Alternatively, you can check the flow with the Doppler. There has always been a debate over small versus larger craniotomy. Some neurosurgeons still prefers to use a larger craniotomy, especially with the ruptured aneurysms. However, many publications and their results have shown that the majority of these aneurysms can be clipped through a supraorbital keyhole mini craniotomy without compromising the outcome. Even intraoperative ruptures can be dealt with the same efficiency as in larger craniotomy. In fact, if you realize the working space to deal with the aneurysm, it is nearly similar in both mini craniotomy and large craniotomy. The rest of the larger craniotomy's exposure is actually occupied by the brain. I believe the surgeon should decide the craniotomy size according to his experience and comfort in the best interest of the patient. There is a reason that I thought of clipping of Acom aneurysm endoscopically via supraorbital keyhole craniotomy. Last year, we described an innovative extraaxial technique for performing ETV by a supraorbital keyhole approach using subfrontal route. Let's have a brief description of extraaxial ETV, which was the basis of attempting Acom aneurysm clipping endoscopically. And my rationale for an extraaxial approach of ETV was infrequent but serious complications in 2 to 15% of cases. We often assume that going through the brain during conventional ETV is innocuous, but it is not. This is a 2-week postoperative MRI after a conventional ETV. You can see the brain insult along the track site. Going through the cerebral cortex in conventional ETV may produce a tract-side hematoma, pharyngeal contusion, and minor intraventricular hemorrhage. Rarely, basal artery injury is a catastrophe. Mammillary bodies may get injured during fenestration, and the irrigation-induced hypothalamic dysfunctions may result in cardiovascular and endocrine changes. And conventional ETV is technically difficult in slit ventricle syndrome. Safe negotiation and maneuverability of the endoscope is a difficult task if the foramen of Monro is narrow. Stoma creation is really challenging when the premammillary membrane is thick and opaque. Narrow premammillary and prepontine space, especially in case of brainstem glioma, is another issue. During repeat ETV, bed scarring at the third ventricle floor is a nightmare. So we circumvented all these issues via a subfrontal extraaxial approach. We fenestrated the lamina terminalis using an endoscope via a supraorbital keyhole approach. Let me show you a short video of extraaxial ETV, as the dissection done in the extraaxial ETV is the same required to expose an Acom aneurysm. Please focus on the dissection in the surgical video of an extraaxial ETV. We can discuss the detail of extraaxial ETV in some other webinar. Here, the frontal lobe is being dynamically retracted with suction and endoscope till release of CSF. Immense patience is required during initial brain retraction. Here we can see the right optic nerve enclosed in the arachnoid membrane. It is being opened, and sometimes it gets opened with traction only. Further arachnoid dissection is being done towards opposite optic nerve using a hook. I preferred a nerve hook as it lifts the arachnoid through which the small perforators can be seen and preserved. If you want, you can use endoscissors and microscissors. Some minor bleeding can occur from the dura as the endoscope and suction graze against it. This minor bleeding is self-limited. Although the purpose of this surgery was to fenestrate lamina terminalis for managing hydrocephalus, but you can consider this dissection as being done for an unruptured aneurysm. The more arachnoid dissection is required for unrestricted retraction of frontal lobe. For aneurysm clipping, you will require opening of sylvian fissure a bit till ICA bifurcation is seen. The sylvian opening can be done in a inside-out manner. As there is no subarachnoid hemorrhage in this case, it looked pretty, but in presence of subarachnoid hemorrhage, bloody field is expected and more careful dissection is required to preserve perforators. This arachnoid dissection should be tailored to the need of the exposure. A meticular dissection can expose the suprasellar region widely. Careful arachnoid dissection can expose the bilateral internal carotid artery, bilateral anterior cerebral artery, anterior communicating artery, and the perforators. Similar sort of dissection is required for aneurysm exposure. Here you can see the opposite A1. The lamina terminalis is being opened with sharp bayonet forceps, and the fenestration will be widened with the same forceps. You can look inside the third ventricle. And this is the final look after extra-axial ETV. You must have noticed that the similar dissection we all used to do to expose the aneurysm with a microscope. So this dissection is feasible with the endoscope. You also must have noticed that you can easily dissect the anterior circulation vessels. The only requirement is the patience. After doing 40 such cases of extra-axial ETV, we decided to step up to the challenge of an Acom aneurysm. If we see the literature about fully endoscopic clipping of Acom aneurysm by a supraorbital keyhole approach, we will get these two publications. Dr. Sharma from India published a successful endoscopic clipping of 7 Acom aneurysm, while Dr. Ferraris from Brazil clipped 1 unruptured ICA bifurcation and 1 unruptured MCA bifurcation aneurysm. So technically, full endoscopic clipping is feasible, and Dr. Ferraris considered this as one step closer to the robotic surgery. This was our first case of a lady with 4 days history of subarachnoid hemorrhage in the interhemispheric fissure and sylvian fissure. And CT angiogram showed a superiorly directed Acom aneurysm and the right A1 was dominant. When we saw the reconstructed image, we noticed that from a terional view, right A2 was in front of the aneurysm, which looks difficult to clip, while from a supraorbital view, more favorable anatomy appeared for clipping. The viewing of aneurysm and adjoining vessel from the clipping angle is very important step in surgical planning. The surgeon can have the idea of location of opposite A1 and A2 from the clipping angle by looking at CT angiogram. One should always observe the relationship between the aneurysm and bony landmark, as bone serves as navigation guide for dissection. For clipping, we made a standard right supraorbital keyhole craniotomy. And this is a usual craniotomy setup. You can divide this semi-linear shaped craniotomy compartment into 3 parts. The lateral part is used for the endoscope, the medial part is used for placing the suction cannula, and the central larger part is used for working instruments. You can switch the compartment according to your needs. We used routine instrument of microsurgical clipping, and we used a 4 mm diameter scope like we use for pituitary surgery. Both 0 and 30-degree viewing scope can be used according to the need. Side viewing scopes are really helpful for superiorly and posteriorly directed aneurysm, checking clipping blades and preserving the perforators. The surgeon can use a scope holder as per their comfort. In the surgery, the frontal lobe was dynamically retracted to see the right optic nerve. The arachnoid over the right optic nerve was opened and dissected. As I told, I prefer nerve hook by which the arachnoid can be lifted and a small perforators can be seen through it. The right ICA was traced up to its bifurcation. Right A1 identified and prepared for temporary clipping. Similarly, the left A1 was visualized. Then the right A1 was traced distally up to the A1 Acom junction. Blood clots were removed carefully to preserve perforators. The aneurysm remained hidden behind the gyrus rectus, which was then sucked out. And you can see the right A2 here. For safety, the further dissection was done under a temporary clip application. The cloths were sucked out to view bilateral A1, A2 and the aneurysm. Then a curved clip was applied to occlude the neck. A tiny neck remnant was left over Acom and we thought of putting a mini clip over it, but decided against it, as the opposite A2 was filling through the Acom and the extra clip could have jeopardized it. The lamina terminalis was then opened and the wound closed in layers. The first post-op day scan looked good. The patient remained drowsy for next 2 days. DSA showed satisfactory clipping but vasospasm. The lenticular strides were barely visible. Following nimodipine installation, the circulation improved. He gradually improved and could be discharged without any infarcts or neurological deficits. After seeing this, you must be wondering that what if aneurysm ruptures during surgery? Is it manageable with endoscope? Let's see that. A lady presented with SAH along with hydrocephalus and CT angio suspected an anteroinferiorly directed aneurysm arising from left A1A2 junction, which was confirmed on DSA. Now, look at the CT angiogram films and note that from a frontal view, right A2 was hidden behind the left A1, the right A1 and Acom were away from the neck, and right A1 was not filling the aneurysm. We approached from the left side. As there was hydrocephalus, we inserted an EVD first. The initial dissection was same told earlier. Like microsurgical clipping, the rules of aneurysm surgery remain the same. Expose the ICA, prepare proximal A1 for temporary clipping. And these are edited videos and some part are moved fast. So don't judge the movement. The surgery requires slow, careful and steady dissection. The aneurysm was lying in the interoperative space below the plane of planum. The interhemispheric fissure was then opened to expose the neck. And while I was sucking the blood clot near the neck of the aneurysm, it got ruptured due to a traction over fundus. The endoscope was readily withdrawn and cleaned. The assistant placed a second suction to clear the field and a temporary clip was applied over the previously defined proximal A1. And this contained the bleeding. Under suction over the rupture site, a permanent clip was applied over previously defined neck. The surgical field was irrigated with saline and the adequacy of clipping was confirmed. Then the lamina terminalis was opened. The lady did well and vasospasm did not occur. The follow-up CT and DSA showed satisfactory clipping without infarcts. Now the next question is, will it be possible to endoscopically clip aneurysm in presence of thick SAH? Let's see that. In middle is a lady with GCS 14 and no deficit presented with thick SAH. CT angio showed an anteroinferiorly directed aneurysm with dominant right A1. We placed EVD to relax the brain. The right supraorbital approach was used. Although we haven't used it yet, you can increase the exposure by 60% by removing the orbital rim. Alternatively, you can extend the lower part of the skin incision by 1 centimeter transversely along the Langer line. This will allow you to make a slightly larger craniotomy than the usual supraorbital craniotomy. We encountered an extensive SAH in this case. The initial arachnoid dissection took a longer time than usual. One can use the fixed retractor if required. I generally use dynamic retraction with suction cannula as retractor occupies the space. The dissection need to be meticulous to save the perforators. An anteriorly directed aneurysm hides the view of opposite A1A2 junction. You need to go over the fundus to visualize it. This manipulation of fundus increases the risk of rupture. After a temporary clip application, you can apply a tentative clip over the aneurysm neck and quickly remove the temporary clip. This strategy shortens the temporary occlusion time and secures the fundus to a certain extent. By doing this, the surgeon need not hurry in dissecting the aneurysm. You can very well go all around the aneurysm and proceed with circumferential dissection. Here I am doing the circumferential dissection. In this case, the tentative clip blade caught a perforator. The close-up endoscopic view provided a better assessment. With more dissection, we confirmed the position of contralateral A1 and A2. Here is the contralateral A1. The subarachnoid hemorrhage was so extensive in this case that we could not see many perforators clearly. But this would have been the case even with the microscope. Here you can appreciate the contralateral A2. A temporary clip was then reapplied, the tentative clip was then removed, and this led to the bleeding from the previously ruptured site. If we would have gone for circumferential dissection without a tentative clip strategy, this would have been a mess. The final clip was then reapplied under vision, and the cord perforator was cleared off. The clip blades was then again rechecked for the adequacy of clipping. The temporary clip was then removed, and at the end, the lamina terminalis was opened. The lady could be extubated on the table without any motor weakness, and this is the first post-op scan showing a relaxed brain and some clearing of SAH. It looked as expected. Surprisingly, even with this thick SAH, visual span did not occur. No infarcts were seen, and clipping looked good. Subsequently, on follow-up, she got hydrocephalus requiring a shunt. Sometimes you need jugglery with the clips. Will it be possible using endoscope? Let's see that. This was an anteromedially directed aneurysm with dominant left A1. After initial dissection, here you can appreciate A1, A2 junction and the aneurysm. While I was dissecting the aneurysm, it got ruptured. A temporary clip was applied on ipsilateral A1, and a tentative clip was applied over the aneurysm fundus. But this occluded only aneurysm partially. During further dissection, it bled again. A second section was brought in and kept at the rupture site. The previous clip was removed and tentatively reapplied to contain the bleeding. There was still a ooze from the ruptured fundus, so we applied a mini clip over it. A further dissection revealed that there is still a neck remnant, so we applied a temporary clip on both A1. After that, the first clip was advanced. Then the temporary clip over opposite A1 was removed. And then the mini clip was removed. But this clip jugglery is not over yet. We realized that the permanent clip has caught the wall of opposite A1. This was delicately adjusted and the ipsilateral temporary clip was then removed. This whole jugglery injured the basifrontal part of the brain a bit, including the olfactory bulb. The lady suffered from severe vasospasm in the right ACA and MCA, for which she received intra-arterial nimodipine. She got a right caudate infarct and remained dull for nearly 2 weeks and later improved. This is a 3-month follow-up CT. She can walk independently. Clipping of unruptured aneurysm is quite easier with endoscope. In India, as we do not have any screening program for aneurysm, we mostly get ruptured aneurysm. Getting a chance to clip an unruptured aneurysm is quite rare in India. This patient came after a history of headache followed by a fall. The CT showed a left temporal contusion with minor subarachnoid hemorrhage in left sylvian fissure. We did a CT angio to rule out an MCA aneurysm, but it showed an anteriorly directed Acom aneurysm with dominant right A1. DSA also did not show any MCA aneurysm. After initial dissection, here you can appreciate A1, A2 and the aneurysm. In this case, although the burr hole was placed for EVD, but we did not require an EVD. The neck was dissected circumferentially and carefully. The temporary clip was applied on proximal A1. Then the aneurysm was clipped with a straight clip. After clipping, the aneurysm was dissected circumferentially to check the tip of the clip blades and opposite vessels. Here is the post-op day 1 CT scan. This is the follow-up scan and check angiogram showing exclusion of the aneurysm. Let's have a look at the other cases as well. This is an anteriorly directed Acom aneurysm with dominant left A1. The patient presented with right gyrus rectus bleed with minimal subarachnoid hemorrhage. The aneurysm was approached from the left side. The gyrus rectus hematoma was partially sucked out and a neck was defined. The aneurysm was clipped with a straight clip. Distal clip blades and adjoining vessels were ensured. And this is the first postoperative day CT scan. Later scan showed a right caudate infarct. On DSA, the caliber of all larger vessels were good and no aneurysm opacified. She remained dull for some time, but improved gradually. She can walk independently. This is an anteroinferiorly directed aneurysm with dominant right A1. Aneurysm was approached from the right side. Right A1, A2 and aneurysm are appreciable here. A temporary clip was applied. The aneurysm neck was dissected. A straight clip was used for final clipping. Distal clip blades and adjoining vessels were found okay. The first post-op day scan looked good. No vessels was buckled. This is a follow-up scan. No infarcts, no residual aneurysm. Since no residual aneurysm on check DSA. This was an elderly lady with medially directed Acom aneurysm with dominant right A1. Same sort of dissection. Sorry for the poor video quality. Bilateral A1, A2 position was ensured before final clipping. We used temporary clip on bilateral A1 in this case. Clip blades did not catch any other vessel. The patient could be extubated on the table without any motor deficit. This was the first post-op day scan, looking satisfactory. Unfortunately, on the first post-op day at middle of night, she developed inferior wall myocardial infarction and could not be rescued. The posteriorly directed aneurysm clipping is a bit treacherous due to the presence of the perforators even with the microscope. In this case, although the left A1 was dominant, but from left side view, the A2 fork appeared closed and was hiding the aneurysm. While viewing from the right side, we were able to see the neck of the aneurysm. So we approached from the right side. For an appropriate size clip, the clip angle was very difficult. So we used the anterior half of larger curved clip. She did not develop any infarct and there was no residual aneurysm. This was a superiorly directed aneurysm with a very thick perianeurysmal clot. Left A1 was dominant. During endoscopic clipping, we could identify adjoining vessels comfortably. First post-op day scan showed leg sprain, and follow-up CT and angiogram showed no infarcts and no residual aneurysm. Of our 15 endoscopically clipped aneurysms, 14 patients did well, while 1 died of cardiac cause. The cosmetic outcome was also satisfactory. We have published our surgical technique in Neurology India and the tricks for managing intraoperative rupture in acta neurochirurgica. To conclude, fully endoscopic clipping of ruptured Acom aneurysm is technically possible by a supraorbital keyhole approach using routine instruments. The rules of the aneurysm surgery should be strictly followed. Thank you for your kind attention.
Thank you, Professor Sanjeev. Very interesting. I learned a lot from your fantastic techniques using the endoscopic, just only endoscopic endoscopic clipping for the Acom aneurysm. So very fantastic techniques. So I have a question. I have several questions for you now. And my first question is, so our colleagues asked you in the website on the chat box as well. So who hold the microscope during your manipulation dissection? Because the microscope will hold some other person, maybe. So sometimes you just using a microscope and the dissection left hand suction tube for
Endoscope,
left hand.
endoscope, endoscope.
Endoscope, the endoscope and instrument, but sometimes somebody hold the endoscope and you both taking two hand surgery.
Yes.
So
This is a very good question. And if you recall the videos, in the initial part till the release of CSF, uh, I am using both my hands. One hand is the suction, one hand is the endoscope. Once I reach the optic nerve, the assistant hold the endoscope, and my right hand will become free. So my left hand will hold the suction, and right hand will hold the key instrument. It may be force, sharp bayonet forceps or a hook or a micro scissor, anything. So initial part, it is a two-hand technique. Once I reach the optic nerve, it is a three-hand technique. The assistant hold the endoscope, and for a right side approach, the assistant is standing on the right side of me, and for a left side approach, assistant is standing on the left side of me. So at the main part of dissection, it is a bimanual dissection, and the assistant is holding the scope, and my both hands are working. If I personally has a habit of not using the scope holder, this is just on me. But if you are comfortable with the scope holder, the scope can be connected to the scope holder, so you can avoid that part of the assistant part. But you will require an assistant in case of rupture to put a second suction.
Yeah, in case of rupture, very dynamic state for the intraoperative scene.
Yeah.
So maybe more two handle or two suction may be essential to control the breathing. Yeah, I think. So and so do you mean that do you use the brain retractor or to expose the surgical field? I can see that any retractor in your surgical field.
Yeah, it was there in one of the case. I feel that if you are dealing with the anteriorly directed aneurysm or inferiorly directed aneurysm, you might not require a retractor at all, because the aneurysm orientation is like that. Once you are dealing with the superiorly directed or most importantly posteriorly directed aneurysm, you will require a detector with the 30-degree scope, because your position, the medial frontal part of the brain will obstruct a bit, so you will require a very thin retractor blade for that.
Oh, yeah, that's right. So sometimes maybe assistant in the scope can retract the brain directly. So yeah, very effective.
Absolutely correct, sir. So there are three instruments there to retract the brain if I am not using a retractor. One of my left hand is a suction. One of my instrument, which the key instrument with no central part, which is in my right hand, and third one the assistant with the endoscope. So keep the endoscope, cotton patty, keep the endoscope over it, and use endoscope also for a little bit of retraction. And if you see the angle of the endoscope from a lateral part, and it has to direct medial part. So it is like a 45-degree view of 45. The long axis of the endoscope is like a 45-degree. So that part of the brain can be retracted with the endoscope shaft.
See. So any other question from the audience and Roger and Ben? How about you?
Yes, and really impressive techniques, Professor Senji. And I have some questions. So concerning the use of the endoscope. So Do you sometimes need to use the 30 degree endoscope or just 0 degree is enough? And also my second question is about for those patients having large frontal sinus. So would you still approach it, this approach?
Regarding the 0 degree and 30 degree endoscope, most of the, as I said earlier, if you are dealing with the anteriorly directed or inferiorly directed aneurysm, 0 degree is quite sufficient one. Once you have to see posterior part, like in a superior redirected or posteriorly directed aneurysm, you will require 30 degree or 45 degree as per your convenience. Regarding frontal sinus, large frontal sinus, I do not restrict my approach because of the size of the sinus. I am quite comfortable with externalization of sinus. I will make a usual craniotomy, supraorbital craniotomy. If sinus is big, I will pack with the little bit of temporal muscle which can be harvested from the lateral part, and I will seal it with a bone wax. So I am not hold myself because of that large frontal sinus till now.
Also for your approach, is it easy to visualize the contralateral A2? The contralateral side, the A2, is it always visible, easy to see?
Yeah, contralateral A2 is always visible. For anteriorly directed aneurysms, I use the strategy of tentative clip. So first I apply a tentative clip, then I go to the contralateral A2. For a superiorly directed aneurysm, I will see bilateral A1 and bilateral A2 before final clipping. So I adjust the exposure according to the orientation of the aneurysm. But in all cases, we must see the bilateral A1 and position of the A2. You can have some idea of, as I said, looking at the preoperative CT angiogram reconstructed film by a clipping angle. Sometimes the opposite A2 is just behind that, and it cannot come in the clipping angle until you are using just anterior to posterior clipping angle. So in that case, you can just have a little bit of glimpse where is that contralateral A2, and you need not to dissect completely.
Yes, Professor Bukhtiyar Burhani.
Pardon?
You have a
Yeah,
great...
thank you very much. Very nice lecture, Kumar. Congratulations. Just as I thought, most of the post-op CT scan, there were much air inside, non-municipally. Is it a problem of endoscope, or is it possible to just wash out after the operation the operating site of his other problem?
No, that was actually when we closed the dura. We try to fill up the intracranial part with the normal saline, but still little bit of air is always there. So that air has not created any problem till now. So even with the microscopic surgery, if you do a post-op CT scan on day one, you might get some pneumocapillars or little bit of air. That is not because of the problem of endoscope. That is just a residual layer which persists after craniotomy.
And thank you very much. And is there any issue about the scar tissue at the site of the eyebrow? How do you solve this problem after operation?
Sir, I make incision through the eyebrow. So of my all extraaxial ETV and endoscopic clipping aneurysm, I remember there was a problem with the scar with in one patient that there was a young girl. For that, I have to go for a scar revision. The brow look splitted in that patient. So I did revise the scar. Otherwise, I have not faced this problem till now.
No.
Okay, thank you.
Yes, Dr.
Thank
Sujan
you.
Sharif.
Dr. Sujan Sharif, do you have some question? now yet.
Thank you, Professor, for your excellent presentation
Thank you.
on endoscopic. It is very newer for us. I am Dr. Sujan Sharif from Bangladesh. Now I am in a fellowship in Bantane, Fujita, in Japan. So I have one question. Do you know that the endoscopic procedure is sometimes hazardous due to blaring of the endoscopic tip, frequently blaring. So how you will manage that blaring problem? And number two question is the single shafted instrument is better for endoscope. So do you use this type of instruments? And sometimes irrigation suction system, continuous irrigation suction is better, which I saw in Fujita Hospital. What is the points regarding this? Thank you, sir.
Regarding blurring of vision, that is an inherent problem with the endoscope wherever you use it. So what we used to do, we keep the endoscope inside and ask assistant to pour some saline over the shaft of the scope. It
Okay,
get
okay.
usually clear. But if you want and you are not at the very critical moment of your surgery, you can take out and clean it. Second question was single shaft instrument. They are very, very useful instrument. I do use some at some time at during clipping single shaft clip applicator. And third question was I forgot. Sorry.
So suction irrigation system.
Suction irrigation system. I usually don't use that. I manage somehow without this suction irrigation system. But we used to use that suction irrigation system in pituitary surgery, but not
Yes, sir.
required.
Yes, sir.
We use it in pituitary surgery.
Thank you, sir, for your excellent presentation. We are inspiring after seeing your surgery. Thank you, sir.
Welcome.
So we might have some another questions from the audience. And how was the vasospasm after the subarachnoid hemorrhage? The frequency was different using the microscope or endoscopic clipping. How about the difference? Do you have some opinion about it?
Yeah. I don't think the endoscope will change the incidence of vasospasm. Vasospasm was seen in 2 of my cases, of 15 cases. If I go through the literature in 2023, there was a study published from Japan, and they have shown when they use the endoscope along with the microscope as endoscopic assisted microsurgery, the incidence of post-clipping infarcts were less when they use the endoscope. I don't understand the reason why it happened, but I have no clear concept about it. I feel that it will not be any difference because that vasospasm is due to some other pathology, not because of the surgical tricks.
I see. Thank you. Raja, do you have some comment? Sorry.
Yeah.
If you have.
Yeah, first of all, let me congratulate you for this wonderful talk, and it was excellent and daring, I must say. But I'll say that some people may take cues and start their clipping of aneurysm right from the endoscope, seeing your talks, which is not at all recommended. I would like to say about ruptured aneurysms, it is very risky. Only a person of maybe your stature can even attempt it. But unruptured, it is okay. Because what happens in ruptured, I will tell you the incidence of one of the most famous professors who is the ultimate gurus of supraorbital keyhole approach. So I don't want to name him because you all know him. So what happened once that through this he clipped, he had put a temporary clip, and suddenly there was a rupture and the brain swelled up, and he could not take out this temporary clip. Okay, so ruptured aneurysms, this is a bit dangerous, I think. But of course, unruptured, you may take this as a very novel thing. The first and of course, congratulations to you for for this wonderful presentation.
I do not intend to recommend that you should suddenly switch over to the endoscope, but it can happen in future. What is written in the future, nobody knows. If we talk about the intraoperative rupture and the events and the panics, are these things we have not faced in microscopic surgery as well? The intraoperative rupture, whether it is microscopic or endoscopic or open surgery, it is a catastrophe. Sometime and the outcomes and especially when it is uncontrolled rupture, what the incidents you told, if it is uncontrolled rupture, brain swollen, even with the microscope, the results are not going to be very different. Yes, you can take out the clip, rescue some of it, but still I feel that that would not be different. Yes, endoscopic surgery, now it is in the initial part, it will take time, but it may set a trend. That's what my comment is.
Yeah, thank you. Thank you. We learned a lot from a technique, but young neurosurgeon don't start endoscopic surgery, endoscopic clipping. Just first we need to young neurosurgeon have to start with a microscope. After that, after run the technique sufficiently, they can try the endoscopic clipping. Yeah, I think. Yeah. Thank you.
Yes, certainly, sir. Certainly.
Yeah, thank you. So, Dr. Ben, can we move on to the next session, next presentation? It's okay?
Yes, yes. Please,
okay.
If there's no more question, then please go on to move to the next.
Thank you, Professor Sanjeev Kama. So I'll see you next time. Angelo, thank you. Okay, now let's move on to the next presentation. So next is Professor Shiji Young. It's okay? So it's a great honor for me to chair your session, the second session. Now his title is Cerebral Hemodynamics of ECIC bypass for complex middle cerebral artery aneurysms. So it is very looks so interesting and amazing presentation for us all. So please start your presentation. Thank you.
Okay. Thank you for the invitation from ACNS, and thank you for the introduction of from Kimura. Today, I'm very honored to have the chance to present my brief report. The title of my research is Research of Cerebral Hemodynamics of extracranial to intracranial bypass for complex middle cerebral artery aneurysms.
Okay, great. Thank you.
The definition of complex cerebral middle aneurysm is intra-aneurysmal thrombosis, infected aneurysm, or atherosclerotic thickening or calcification arteries in the neck of the aneurysm, or diameter larger than 2.5 centimeter, or involvement of important perforators and harboring large angulation. The annual rupture risk of complex intracranial aneurysm is about 5% per year, and there is no optimal treatment. The treatments included conservative treatment with high morbidity and mortality, and vascular interventions with 75% complete occlusion rate at 6 months, and cerebral revascularization, that is ECIC bypass with or without aneurysm tramping. According to previous literature review, revascularization is very important. BOT examination is very important for the assessment of the collateral circulation. For BOT with negative results, bypass with aneurysm trapping is usually used, which can achieve nearly 100% complete occlusion. but with operation rate infection risk of about 15.4%. Is there any other optimal treatment? Let's see some warning cases. This case is risk is accepted endovascular coil treatment for 4 times, and the recurrent rate is unacceptable. This warning case, this 34-year-old woman diagnosed with bifurcation aneurysm of ICA experienced cerebral infection attack after endovascular treatment. The CTA reviewed occlusion of the MCA trunk at 1 year after embolization, and STA-MCA bypass surgery was performed. The principle of cerebral revascularization included ECIC bypass with aneurysm trapping and without aneurysm trapping. The surgical strategy included bypass options: superficial temporal artery to middle cerebral artery bypass, superficial temporal artery to radial artery to middle cerebral artery bypass. How about aneurysm treatment options? We divided into 4 options. That is bypass with aneurysm trapping, bypass with simultaneous partial aneurysm trapping, bypass with second staged aneurysm trapping, or bypass without aneurysm trapping. This case is the right M1 segment dissecting aneurysm. He was performed by double branches of STA, which was anastomosed to M3 trunks with aneurysm occlusion. He was discharged without any operation-related infection. Post-operative angiography showed that the bypass graft was patent and the aneurysm was visualized in reverse flow. The patient did not complain of any discomfort after bypass. What's more, there are also new infection occurred after bypass. This 31-year-old man with sacral aneurysm of ICA segment and ECAI-M2 bypass was performed successfully. He was exposed to massive cerebral infection at the 6 days after bypass due to robust neck rotation. This case, this 52-year-old man with giant aneurysm of ICA cavernous segment and ECAI-M2 was performed. He also experienced a new cerebral infection, although with patency of bypass graft. What about ECIC bypass without aneurysm trapping? For this case, after bypass without aneurysm trapping, true flow formed. That is reversed flow from extracranial circulation and integrate flow from intracranial circulation. We hypothesized that when aneurysm will disappear when integrate flow, when reversed flow from extracranial circulation suppressed integrate flow. Otherwise, when integrate flow suppressed the reversed flow from extracranial circulation, the aneurysm will not disappear or even enlarge. According to previous literature from 1978 to 1987, Professor Fox of Hopkins Hospital reported the use of a detectable balloon in combination with ECIC bypass for the treatment of intracranial aneurysm. The ischemic intolerance was observed in 9 of 65 patients. One during BOT. Subsequently, ECIC bypass was performed first in 4 of these patients with intolerance of BOT. After bypass, 2 cases tolerated BOT. 1 patient remained intolerant of BOT at 1 day, 1 week, and 1 month after bypass, but tolerated BOT at the 8 months. And then other aneurysm disappeared spontaneous after ECRC bypass. In 1987, Professor Cerebral changed the surgical approach by using permanent balloon occlusion of the parent artery after ECRC bypass. And that is one-stage occlusion to treat 9 patients with giant intracranial aneurysm. These 9 patients were treated without significant post-operative complication. In 1991, Professor Binashvili reported a case of aneurysm disappearance after ECRC bypass alone. The patient present with hemiparesis of the right limb at the BOT and only ECRC bypass was performed. The post-operative follow-up showed that the aneurysm disappeared spontaneously. He hypothesized that it's extremely important to ensure the patency of the bypass graft before permanent occlusion of the parent artery. There is no urgency to occlude the parent artery after bypass, and there may be surprises in the wait and see period. A BOT is recommended before permanent occluded parent artery to ensure intolerance of ischemia. Before permanent occlusion is recommended to perform a BOT to ensure that the ischemic is tolerated. The force of the balloon is relatively precise and controllable for occlusion of parent artery. However, this procedure is only limited to case report. We have some puzzles after ECRC bypass alone. After ECRC bypass with aneurysm trapping, how to overcome the incidence of post-operative cerebral infection of about 10%. For patients with old age and a poor intracranial bypass vessel, what about poor quality of bypass graft? What can be done for complex aneurysm not passing BOT procedure or involved important perforators? Is the permanent occlusion of the parent artery necessary? What are the hemodynamic changes after ECRC bypass alone? Is there a remedy if the aneurysm does not disappear after bypass alone? After thrombosis of aneurysm achieved, does the risk of natural rupture disappear completely? We defined the staged therapy, which included stage 1 ECRC bypass without aneurysm trapping, creating competing flow in the integrate from intracranial circulation and reverse flow from extracranial circulation. The second stage in treatment dependent on the aneurysm secondary change. If the aneurysm does not disappear, clinical follow-up does disappear. Clinical follow-up was continued. If the aneurysm does not disappear, stage 2 segment treatment is performed to control the integrate flow. This is the flow chart. In this study, 40 flow MRI for parent artery and bypass graft and CFD analysis based on CTA and ultrasonographic was used to assess hemodynamics. Let's see this case. This right MCA aneurysm, he was performed ECRC bypass alone. After during procedure, we clipped the daughter sac without aneurysm trapping. After ECRC bypass alone, post-operative CTA reviewed patency of bypass graft, occlusion of parent artery, and aneurysm shrinkage. Post-operative 3-week CTA reviewed spontaneous disappearance of aneurysm, occlusion of parent artery and patency of bypass graft. The 40 flow indicated that the reversed flow from STA first increased and then decreased, which contributed to the aneurysm disappeared. CFD analysis revealed that washer under streamline velocity significantly decreased after bypass. This 62-year-old man with right M1 aneurysm was performed STA-RA-M2 bypass, and the aneurysm disappeared after bypass. The CFD analysis reviewed the same change, that is, the velocity and blood flow of STA first increased and then decreased at the sixth day or 7th day after bypass. This 27-year-old woman was diagnosed with right MCA spinal aneurysm due to headache discomfort. She was treated by STA to M4 bypass, and the aneurysm gradually disappeared after bypass. This aneurysm enlarged after bypass. After bypass, she was treated by endovascular embolization with with aneurysm remains. However, after 1 year after embolization, aneurysm also disappeared. This 40-year-old man with circular aneurysm of left MCA territory, and he was treated by STA-RA-M2 bypass. Unfortunately, this aneurysm does not disappear. Dynamic changes of aneurysm of bypass show that the bypass artery gradually shrank and became in a suppressed state. This patient was not treated by second stage treatment. We can see the bypass graft was patent after bypass. However, after 10 months after bypass, the bypass function was in suppressed state. After neck compression, the ECA angiography showed that the bypass can perfuse flow into the brain. Hemodynamic analysis after bypass also showed that the same change, which that is, velocity and flow first increased and then decreased at the sixth or 7th day after bypass. Hemodynamic analysis after bypass showed that the aneurysm was still exist. The washer and the streamline velocity does not decrease. This left ICA aneurysm, he was treated by STA-RA-MCA bypass. After bypass, the CFD analysis, the 40 flow reviewed that the reversed flow from STA first increased and then decreased without aneurysm disappeared. CTA examination 2 weeks after surgery bypass patency with partial stenosis, aneurysm still visualized. This patient was treated by secondary RCA ligation. Re-examination of CTA 1 week after RCA ligation reviewed parent artery graft patency was patent stenosis of bypass graft and aneurysm disappearance. The occlusion is ECIC bypass alone complicates cerebral hemodynamics of aneurysm, which may cause uncertain future of the aneurysm. ECIC bypass with second stage aneurysm trapping can be used to treat partial complex intracranial aneurysms, causing complicated hemodynamic changes. Compared to preoperative hemodynamics of bypass graft, post-operative 40 flow analysis reviewed a turning point characterized by first increase and then decreased trend, which might occur while 1 week after bypass. That is the turning point. The post-operative hemodynamics in parent artery was different, which might be associated with aneurysm secondary change. For patients with aneurysm disappeared, a decreased tendency of flow and velocity after TP was observed. Conversely, for patients with aneurysm enlarged or unchanged, an increased tendency of flow and velocity after TP was observed. In some patients after bypass, the wall shear of the aneurysm is reduced, slowing down blood flow and favoring thrombosis. Besides, preoperative CFT analysis can verify the presence of rupture-prone areas, which can be addressed during surgery. Moreover, the enlightenment is ECIC bypass alone can result in partial occlusion of the aneurysm. Otherwise, second stage treatment was necessary. The supply and demand of blood flow of bypass graft is a dynamic process, and there is a competing offset between reverse flow and integrate flow competition, which determine the changes of the aneurysm. Second stage treatments mainly focus on controlling and integrate flow from intracranial circulation, and ICA ligation or intervention therapy was used to promote aneurysm shrinkage and occlusion. The absence of the aneurysm rupture during the follow-up does not mean that the natural history of aneurysm rupture has been changed, probably because the follow-up time is insufficient. In the future, we will explore further, that is, hemodynamic changes in velocity and flow of bypass graft after second stage treatment needed to be further studied. Is the second stage treatment preferred endovascular coiling or permanent occlusion or flow diversion stent? Is it complete embolization or partial embolization? Or how to control the residual remaining after interventional embolization? Can a relatively standard surgical process be established for complex aneurysm? One stage of bypass with a specific time window for second stage treatment. My personal viewpoint is the first line treatment is ECIC bypass with simultaneous aneurysm trapping. However, for cases with important perforators or intolerant with BOT, ECIC bypass with second stage aneurysm trapping can be viewed as second line treatment. At last, I'll show the introduction of our cerebral vascular surgical team. The surgical team of Cerebral Vascular Department of Nanjing Zhang Tower Hospital has 3 doctoral supervisors and professors. Currently, it routinely carries out extracranial bypass to extracranial to intracranial bypass, carotid endarterectomy, intracranial vascular system reconstruction, endovascular intervention, keyhole technique, and hybrid operation of endovascular treatment and microsurgery. with annual operation volume of over 1,200 cases every year. At last, thank you for the Professor Zhang Dong, my doctoral supervisor, director from the Department of Neurosurgery, Beijing Hospital. He helped us to resolve some puzzles. Thank you for your attention.
Thank you, Dr. CG Yang. So very interesting and fantastic presentation. So you showed your treatment strategy for a difficult aneurysm using a staged operation. First, you perform the ECIC bypass alone. After that, second surgery to control the aneurysm disappearance. Sometimes you need to perform the trapping for the aneurysm if possible. They're using the hemodynamic analysis for the aneurysm status is very important concept to evaluate the status of the aneurysm flow. It's very, very important. I totally agree with your concept and your strategy to performing your actual surgery. Were fantastic presentations. Thank you. And
thank you.
Yeah, so very, very nice too. So my first question is, this is just a fundamental question. So if you perform the antegrade flow, keeping the antegrade flow, you perform the bypass surgery. In such a situation, not everybody can imagine their augmented flow can rupture the aneurysm status in some chance to rupture by the augmented flow. Do you have some comment to just waiting for the aneurysm shrinkage? Thank you.
Excuse me.
Sorry. Okay, antegrade flow and the bypass flow. So intra-aneurysm flow increase, maybe it can be imagined.
Yes.
So in such a situation, rupture may occur. So do you have some comment?
It's a good question. In our clinical practice, aneurysm disappear after ECIC bypass alone only exists in several cases. For most cases in our research, the aneurysm will not disappear, and which need to treat with second stage operations.
Yeah, rupture while waiting for the aneurysm disappearance may sometimes the aneurysm rupture may occur.
No, there's no aneurysm rupture occur during our research.
Okay, and my second question is, what is the optimal condition, hemodynamic condition for decrease the aneurysm postoperatively? So you mentioned in the presentation that wall shear stress should be decreased, and the velocity and the flow should be decreased.
Yes.
Okay. In these conditions, these conditions achieved by your ECIC bypass surgery, the aneurysm will disappear while waiting. It's okay?
Yes. After ECIC bypass, alone, a series of CTA examination was used. If the aneurysm, besides the CFT analysis and the 40 flow MRI were also used to monitor the hemodynamic changes after bypass. If in our study there is a TP point after bypass, after the TP point, if the integrate flow from the intracranial circulation will increase. For these cases, the second stage treatment is necessary. However, for cases with the with velocity or flow decrease after TP, we will choose to wait and see. Maybe there will be a surprise.
Thank you. And after my third question is, after you apply the clip and as a second strategy, you mentioned in a presentation the keeping the perforator patency is very, of course, important point. So, but how do you keep the blood flow of the perforators after the trapping of the aneurysm? So, I mean, do you use antiplatelet drugs after the operation or something like that?
Yes, yes. In our current research, the cases received second stage treatment mainly was acid ligation. For some was performed by endovascular corneal, and there's only one case was performed by pipeline. However, this is only limited to limit the case volume, which need further to explore our case volume.
Thank you. So, Professor Sanjeev, do you have some comment? Thank you
Yeah.
for joining us. Thank you.
I have actually one observation after seeing this presentation. If you see all these cases, whenever the bypass is connected to the distal vessels like M4, the chance of disappearance of aneurysm or shrinkage of aneurysm was good in comparison to when the bypass is connected to the M2 segment. So whenever there is a distance between the aneurysm itself and the bypass segment, when the distance is more, the chance of disappearance of aneurysm was. Am I right, doctor?
Oh, sorry.
Yeah, I will repeat again. I will repeat again.
Translate.
Okay, maybe you repeat one more first, Professor Senji. I can help translate. Professor, can you repeat the question again? Sorry.
What I said that if the bypass segment is connected to a distal segment like M4 vessel of MCA, the chance of disappearance of aneurysm or shrinkage of aneurysm was better than when bypass was connected close to the aneurysm like in M2 segment of MCA.
史医生他的问题就是，如果你的 bypass recipient 如果在M4，那对比起来，你觉得M4做 recipient 还是 M2 做 recipient 比较接近那个aneurysm， 你觉得哪一个会比较好？对于那个aneurysm 的 shrinkage？
Okay, in my viewpoint, the endovascular treatment is the mainstream, and ACNS bypass is the last and important weapon for this complex aneurysm. In our center, aneurysm was treated by endovascular treatment in most cases. ACNS bypass is only limited to several cases.
史医生，他的问题就是，如果你做那个STA MCA bypass， 那你的 recipient 你是想在 M2 还是在 M4？
M2. In most cases, M3 is selected as the recipient segment. because M2 is very deeper and with many perforators, and the bypass is difficult. In most cases, M3 segment is usually okay in our practices.
如果就是你觉得如果那个 bypass 的 recipient 是比较是比较接近的 aneurysm 是好一点，还是还是远一点好呢？
In our viewpoint, the more proximal the better the better outcome. Okay.
Did I answer your question, Professor Sengri?
I couldn't get it actually. I couldn't understood the message. Which one was better for disappearance of aneurysm itself?
He's saying that the more proximal the recipient to the, for example, the M2, then the better the disappearance rate of the aneurysm. So they usually they would consider choosing the M3 as the recipient, but the more proximal, the closer to the aneurysm, then probably because of the hemodynamic changes, the better is the disappearance rate.
Yes, in our clinical practice, the recipient of M2 segment is rarely. For most cases, M3 segment was selected as the recipient area. In our research, we divided the treatment into two stages. First stage, ECRC bypass to create competing flow. We can achieve the aneurysm disappear if the reverse flow suppressed the integrate flow. In other words, we hope the bypass graft can achieve the function. Can achieve the function, which that is to perfuse blood flow into the brain. The second stage is to control the integrate flow if the reverse flow was in suppressed state. So we think that the M3 segment is usually okay for most cases. The M2 segment is very deeper with many perforators, which made the procedure more difficult. Okay.
I see. Dr. Ben, do you have a question?
Yes, I have some questions. I hope Professor Shi can answer me. So it's a very interesting and a very good presentation and very good research work on cerebral hemodynamics. So I have some technical question first. So concerning concerning that you have two-stage surgery. So usually, how would you plan your skin incisions? Do you open do you perform the second stage via the same incision and also the same craniotomy? So this is my first question. So my second question is about the timing between the first and the second stage. So usually, how long would you wait for the aneurysm to disappear before you decide the surgery? So my third question is about in your study. So what do you think about the diameters of the donor to achieve the enough competing flow for the aneurysm to disappear. So do you have some calculations before the surgery about how large the donor, or you need to choose the radial artery? So do you have some calculations before the surgery that you can share with us? So my last question is about if you want to achieve enough competing folds to shrink the aneurysm, does that mean that you need to perform or you need to make a larger anastomosis? Will that increase the reperfusion syndrome in those patients with the bypass?
Okay,
Yeah.
okay. The first question is the incision line. In our practice, frontal temporal approach was usually used. The donor artery was gutted. Was gutted from a frontal temporal scalp. 倒抠出来。There for cases with for the cases with radial artery whatever frontal temporal approach is used. 额颞板 OK
这是用你第二次手术就是用同一个craniotomy， 还有就是同一个伤口吗？
No. The second stage treatment, the incision is ICA ligation, the line of CEA, to achieve ICA ligation or endovascular treatment. We rarely to treat aneurysm with by second stage from surgical approach. For most cases, endovascular interventions or ICA ligation, we just try to control the antegrade flow, but which did not to achieve the antegrade flow to disappear 100% or disappear totally, which we want to control this antegrade flow, which most need ICA ligation or endovascular treatment. We rarely to treat the aneurysm with macrosurgical approach. For
the timing.
Okay. 就是for aneurysm after bypass, the hemodynamics calculation. We also calculate and hemodynamics after bypass. The flow or velocity increase at first, but with different trends. For the first day and the second day after bypass, the velocity and the flow increased significantly. And after the second day, the flow increased gradually. We usually choose to wait and see for the aneurysm during the first 2 weeks. If the aneurysm, if the antegrade flow did not disappear or even increase, we will recommend second stage treatment to this patient. Okay. Okay.
How about the size of the donor? The size of the anastomosis, the size. Do you need to make a bigger anastomosis to achieve the enough completing flow?
The bigger the better. The bigger the better.
Okay. How about the high? If you get the anastomosis bigger, will that increase the reperfusion syndrome?
Hyperperfusion, you mean?
Yeah, the hyperperfusion. Do you have any experience with this?
There's only one case has hyperperfusion syndrome, but no hemorrhage occurred. Hemorrhage occurred. This patient with hyperperfusion syndrome was treated by blood control and with limited input fluids. He was discharged without any discomfort. Okay.
I see.
I see. Thank you.
Thank you. Thank you for your fantastic comments and questions. Enjoyed a lot. I learned a lot so much. So my another question is, how about, so I think that your treatment strategy for the difficult aneurysm case is just for the unclippable aneurysm, right? Is that right? So
yes,
if the,
yes.
yeah,
Unclippable,
okay.
unclippable. Yes.
Yeah, if the aneurysm can be diagnosed as a clippable aneurysm preoperatively, can try to apply the clip first, but the preoperative simulation, preoperative evaluation for the imaging data analysis show that this aneurysm would be a unclippable aneurysm. So you perform the bypass surgery and just alone and the first strategy, and the next following by the second surgery. Do you use our trapping or not? You decide while waiting. Okay,
yeah.
Is that
yes.
right? Okay.
Yeah, right.
So,
unclippable. For most aneurysm, microsurgery or endovascular coiling is the first line treatment.
Yeah.
In our research, this is the unclippable aneurysm.
Thank you. Thank you. So, how about how shall we conclude this session, Ben or Raja? How about the okay?
Yes.
And some another question or comment? Okay, audience.
Yes. If there is no further questions from the audience, then may I conclude this session. And this is a very wonderful night with so many meaningful discussion, all inspiring lectures, and from the two expert speakers. It's a really interesting night that we have today. So if there's no more questions, then I would like to end this session with Kimura Sensei. So on behalf, I'd like to say thank you to all of you for joining this webinar tonight. So on behalf of the Educational Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both the speakers of today, Professor Sanvi Kuma and also Professor Shi Zhirong, as well as the chairs, Professor Kimura, for their time and support for the ACNS webinar. A special thanks to Professor Xu Lin for broadcasting this webinar on the WeChat channel. So until we meet online next Saturday, is a bye-bye from all of us. So thank you so much for joining tonight. I hope to see you next time.